Our community is called Lake Cree Nation. We are located 2 hours northeast of Edmonton. We have a population of 11,000 community members. 7,000 community members live on reserve and the rest are living off reserve. So when I applied to medical school, I always knew that I was going to practice rurally. Seeing that there was a need for a family physician in my community, that kind of was the draw for me to come back and practice here. I take more time with my patient and try to understand where they're coming from. I inquire if they have a fear of the healthcare system, if they haven't seen a doctor in a while, and I ask them why that is. If they've had a lot of traumatic experiences, whether it be from residential school or having, a higher risk home where there was violence, addiction, alcohol use, then I know where they're coming from as well. And that helps me to further tailor our appointments, whether I need to spend more time with someone. It also helps me to keep in mind the mental health aspect of the treatments that we're providing, because I find that mental health is often something that's missed and often something that's not touched on. As family doctors, we might not be as comfortable dealing with trauma or abuse or mental health issues and how that all fits together. When I first moved here, a lot of patients were hesitant to get to know me and hesitant to tell me their story and hesitant to talk about their health with me. At our clinic, we've had a lot of turnover, as most clinics will see throughout their clinic span that they've been open. And there was a lot of fear from our community members that I would only be here for a short time and that I would just leave. Because they had that in their mind, that doctors have been rotating through here, they didn't want to invest in me and invest in that relationship with myself. It took about a year for them to feel comfortable and to feel confident that I was going to stay. So thinking about that for urban physicians, there's a lot of First Nation people that access health in the urban center. It would be starting that relationship with them and being that consistent health figure for them. It would be reassuring them that, yes, come to me if you have an issue. I am here for you. I am your doctor. And I think that's something that they need to hear, that you're investing in that relationship with them and that you're going to be there when they need to see somebody. With that sense of abandonment, that could be something that could be a traumatic experience for them. So if they think that you're not invested in this and that you're just gonna up and leave, then they're not gonna be fully in the physician-patient relationship. A lot of those students who went to residential school are still alive today, and they're still dealing with what had happened to them and their experiences, and they're still on their journey to healing. For us, it doesn't seem like it was long ago. For us, everything that we're feeling is still felt today. And we're seeing it in our children, and we're seeing it in our parents and in our grandparents. We're seeing the fallout of that, and we want that to be recognized, that is an important moment in history that's still embedded in our culture today, and it's embedded in our attitudes and in our thoughts. Even when we're accessing healthcare, it is there.
This place was the former Blue Quills Indian Residential School near St. Paul, Alberta. It was on federal crown land. That's where, from 1931, students from the 7 surrounding First Nations within 2-hour radius went to school from the ages of as young as 2 years old up to 21. The boys and girls were separated. The boys were on the east side of the building and the girls on the west side. We could see each other at mealtime, but we couldn't speak to each other, even if we had brothers or sisters. I was brought up with my paternal grandfather and grandmother, so I missed them, and I missed my uncles, my aunties, my cousins. When I first came here, I also cried in the dormitory at night when we were put to bed. And then I could hear my fellow students on the boys' side, the little boys' side. And then I thought to myself, why am I crying? It's not going to help. So I quit crying. But other smaller boys, especially, I could hear them weeping. And we just followed what we were told, what to do. We got used to this supervision and being watched almost 24 hours a day. Even for myself, after I finished school, I still had this hypervigilance. I was wary of authority figures. It was very heartbreaking to live there, but we kind of got used to the routine. But we missed our parents, our grandparents, our aunties and uncles and relatives on the reservation. I'd like to be treated also for my fellow citizens here in Saddle Lake, my neighbors, my friends, my relatives, to be treated with dignity. We're just people. I used to see pictures of foods on charts, meats, cheeses, breads, and some vegetables. But the diet that we ate was sugary and white flour. I associated these later with the health conditions that I saw in my people in Saddle Lake and other Indigenous people across Alberta and Canada.
When we talk about authority figures, those people who were supposed to be taking care of them and mistreated them, create these negative emotions to authority figures. And that's where that can play into the healthcare system, because being a family physician or being any physician, you are in a position of privilege and you are in a position in which you do have authority over people's health. There's a lot of institutionalized feelings that kind of go back to residential schools. And a lot of our First Nation people don't feel comfortable being in those types of settings. So if you've been to residential school and have to go through the healthcare system today, it could be quite difficult for you and could be quite triggering for negative experiences that you've had in the past accessing healthcare now. So one of the things I want to bring it back to is the TRC calls to action. So one of the calls to action is for our medical system and medical workers to be aware of Aboriginal issues, and that includes health. I would like to see, more physicians and more healthcare professionals becoming more knowledgeable about Indigenous people. It's important to know where we're coming from in order to provide treatment and in order to ensure that follow-up is happening. If you don't know that we don't have physio, or that we don't have a lab here, or that the medication that you prescribed is not covered by First Nation Inuit Health Branch, then you're left wondering, why isn't my patient following through with what I'm telling them? Why aren't they taking this medication? Why aren't they getting this blood work? I mean, for Indigenous health is such a complicated issue. There's so many barriers to accessing healthcare that a lot of my colleagues don't know about. And if you don't know what these issues are, then you can't properly treat an Indigenous patient. It has a lot to do with the access to resources and the resources that are available on reserve. And that's where that knowledge comes in. If you know the patient that you are treating and where they're going to, then you can better tailor your treatment for that patient. We want to see actions made to close the gap between healthcare disparities between First Nation and non-First Nation people. And that's the biggest one, because that affects our mortality and that affects our life expectancy. We want the same thing as every other Canadian. We want safe healthcare. We want access to healthcare. We want healthcare professionals to understand where we're coming from so that we can get that equitable healthcare that the rest of Canadians, also desire.